Okay, I think the flow of people has lessened now, so let's make a start. So this whole session's about opt-out testing in ED departments, and to start off with, can I introduce Katie from THT, who's the Policy and Public Affairs Manager at Terrence, Higgins Trust.
Hi everyone, and I'm going to bring Dan Flusky from National AIDS up onto the stage with me as well. So I was initially doing this presentation with Stuart Smith from the Hep C Trust, who I think actually he sends his apologies but might be watching us online, so is here supporting us as well. And we're doing this presentation on behalf of Terrence Higgins Trust, National AIDS Trust, Hep C Trust, the British Liver Trust and the Elton John AIDS Foundation. So we've all pulled these slides together. And really I think we're doing this presentation on behalf of all of us in this room, in the sector, because I don't think there's anyone in the HIV community, whether it's a clinician or a community member, a commissioner, who hasn't in some way been involved in this campaign for the expansion of opt-out testing. So this really is a kind of presentation about the collective effort that we all made to advocate for an expansion of the opt-out HIV testing programme that started in A&Es in London, Blackpool, Brighton and Manchester, and that's now being expanded out by the fantastic team at NHS England. So with that, I will hand over to Dan to do a quick overview of how we got here, and then we're going to tag team these slides. So let's see if my clicker works to start off with. Yeah, there we go.
Shall I grab that? Yeah. Thank you, Katie. Hello, everybody. And if we're talking quickly, it's because we have been told we have got 10 minutes to get through this big change. So, just so everybody kind of is starting off on the same footing, so it's a simple principle here that we were talking about and campaigning for, that everyone who has their blood taken is tested unless they specifically ask not to be. We started off with clear evidence that we knew that it had been working and had been successful in maternity services. There was some great work done by the Elton John AIDS Foundation, trialling opt-out testing in A&Es in South London, and as well as kind of all of the great campaigning and the work that we did from the kind of voluntary sector side. As Katie said, everyone was kind of an ally here for this. We were trying to kind of work with people to align to all get the right policy taken on, and that was including kind of working with and following recommendations by Beaver, Bash, and so on, and clinicians. So it's a mix of charity sector, people working, civil servants, inside government, and clinical expertise as well. And just to kind of go back a second, so Kevin mentioned this in his session this morning, but I think it's really important just to kind of remember the chronology of where we came from and where we got to. So Katie and I from THT and NAT, as well as Elton John AIDS Foundation, were the partners of the HIV Commission, with the commissioners looking at what we need to do in order to get to 2030, and one of the key pillars of that was testing and testing and testing, and a clear call that HIV testing must become routine and opt-out, not opt-in, across the health service. The action plan that we've got at the moment, 21 to 25, was in response to the HIV Commission, and it was published in December 21. And in that action plan, it was committed that there would be £20 million for opt-out testing in very high prevalence areas: Brighton, Manchester, Blackpool, Salford, and parts of London. And that was a really key step to have that action committed to in the government action plan to take this forward. And I think I'm going to now hand over to Katie, which is, where did that 20 million go? What did it do? And what next?
So this is where hepatitis comes in. So when NHS England started rolling out the programme, the fantastic people in the HIV team and also the Hep C Elimination Fund got their heads together and decided that it made logical sense for this programme to be a blood-borne virus programme rather than just an HIV testing programme. We owe them enormous gratitude for that foresight that they had, and so that meant that the programme was able to take place across all of London, not just areas that had very high prevalence of HIV in London, and it also meant that it was able to include Hep B and Hep C. So hospitals across 4 cities started with that testing. and it was success on all measures. This will be familiar to lots of people in the room, and we repeated these 4 things in briefings to MPs, politicians, again and again, in meetings, in written briefings, in letters, that the opt-out testing programme, when it was rolled out in those areas, was saving lives, it was saving money, it tackled inequalities, and it relieved pressure on the NHS. And you'll see from the data on those slides there, which was provided by all of the fantastic people working on the programme, that we had the evidence to back that up. And I think that was one of the really key reasons that we were able to make this case, as we had really robust evidence that we could take to MPs and we could take to government to show that this worked. So I just also next up want to talk quickly about the community sector involvement, first in the rollout of the programme and why that mattered for all of us as community organisations in campaigning for the expansion. So because we as HIV and hepatitis organisations were involved in the inception of the programme and all of the working groups that rolled it out, it meant that we got to know each other better. So us in HIV World, National AIDS Trust, Terrence Higgins Trust, Elton John AIDS Foundation were familiar with working together already, but getting to know the teams at Hep C Trust and British Liver Trust as part of this was new. We're not so used to working as blood-borne viruses in general. If Stuart was here, he would ask me to emphasise, and he would be emphasising the role that he really felt that patient voice played in developing that programme and the importance of that, and that the role that had in the programme being a success. But it also just meant that we all got to know each other better. So as we started to form the campaign to expand the programme, we were working as hepatitis and HIV organisations together. So just here, this is the campaign for expansion. You can see on the slide there an e-action that was on the British Liver Trust website, and this was an action that we all did together. So we wrote an open letter to the Public Health Minister and to Amanda Pritchard. There was a lot of change in ministers during this campaign. So I think we had 3 health secretaries and 3 public health ministers. So we all briefed them multiple times, new MPs, it moved into the ministerial positions, and we went again and again. But this particular open letter that we wrote went to Neil O'Brien, who was Public Health Minister for about 9 months last year. There are lots of community organisations in this room who added their names to that letter, and it also went out as an open call to our supporters, so it enabled us to just get a really clear ask and some publicity for our campaign. We also contacted all MPs who represented areas with a high prevalence of HIV to tell them that the recommendations said that their hospital should be doing this testing, and so that they themselves could also ask the Secretary of State for that funding. So individual MPs were writing, raising this in Parliament, as well as us having this big collective ask, which was really clear. So we facilitated those letters, 3 rounds of those letters to different health secretaries up until November last year. And at that point, there was one more change of health secretary. So Steve Barclay moved to Victoria Atkins, and in the end, we got it over the line. I think not we, but Sir Elton John got it over the line by, he was honoured at a very fancy reception in Parliament for World AIDS Day. It was hosted by the APPGE, and we again collectively were able to say to the health secretary that it would be a good time to make a big shiny announcement about this expansion. And we had this enormous coalition of MPs, civil servants, people working on the programme, charity organisations who were all in line saying that same thing and making that call. It was actually the first funding announcement that Victoria Atkins made as Health Secretary, which I think we can all be very proud of. And the reason for that was that this was a case that was waiting on her desk for her, because we'd all collectively made a really strong case there. So it's £20 million. I know that the future presentations that are coming are going to talk probably more about this. £20 million for 47 more hospitals, which means that now 81 hospitals in England are doing this type of testing. And it's 12 months of funding from the National Institute of Health and Care Research to be spent from April 2024 to 26. So we've got 1 year of funding at the moment, although those who listen to Andrew Gwynn this morning will hear that we're already hoping to start campaigning for an expansion of that. Really crucially, and again, this is credit to the team at NHS England, 10% of that funding is going to HIV community support. So there'll be support for people who are getting a new diagnosis, but also for the cohort of people who are need to be re-engaged in care, so who are being diagnosed, re-diagnosed as they pass through emergency services, and the Hep C Elimination Fund are matching that again. So I'll hand over to Dan for a what next, because this is always only just the beginning.
Yeah, absolutely. I mean, one of the things in policy world is that you have to keep making the case and keep making the case and keep making the case, like painting that bridge in Scotland, get to the other side, you have to go back and start again. So with the new government, we're continuing to kind of push for the success of opt-out and its continuation and sustainability and expansion. We know there's a cliff edge of funding currently, which we need to get expanded. And we need to look at multi-year funding for all areas and look about whether there's potential expansion into new hospitals and to continue the programme, because this is one of the key things. If we're going to get to 2030, opt-out has to stay, it has to get bigger, it has to expand. And when Kevin was talking about kind of, you know, a new action plan in 25 to 30, one of the things that we're really, really focused on is there's not enough time to get things wrong. We need to work out what is going right and double down on them and accelerate that progress. And this is one of the clear and obvious things, which it does cost money, but we're going to have to spend money if we're going to get to 2030. So we have to double down on the things that we work. But we're working with a new government. You know, we have to kind of establish those relationships. There's 300 new MPs. We want to get as many on possible on side. We've got 7 months until the hospitals in the very high prevalence face the funding cliff edge. So that's why we need to make that case now, and we need to keep making that case over the coming months. And we're going to be scoping this out a little bit more as well. So Katie and I and Richard from Elton John AIDS Foundation are doing a workshop this afternoon, kind of looking at the action plan and what next and what are those actions. And some of this is going to be about how do we take opt-out testing forward as part of that next action plan as well. There's an alarm going off and someone has just waved a piece of paper with minutes on it. So I think it's time for us to jump off the stage and the next people, and then I think we do questions together at the end. Thank you.
Fantastic, thank you. I suddenly realised I just dashed from doing a previous presentation. I didn't introduce myself. So I'm Jeremy Horwood. I'm a Professor of Social Sciences at the University of Bristol, and I'm involved in the opt-out testing as well. So next, we've got Sue and Chris. Yeah. So Sue's an HIV nurse specialist in Blackpool and has worked in sexual health and HIV since 1990. And so co-leads the opt-out testing programme that commenced in the Blackpool ED departments. And Chris has 14 years working in sexual health. And Chris is an HIV clinical nurse specialist. And Chris is a co-project lead for the implementation of opt-out testing within their emergency department. So, take it away.
Fabulous. Yeah. Yeah, so here we are, we're going to do a double act, Chris and I. So, Chris is going to press the buttons, because he's best at doing that. Okay, so thank you very much, Jeremy, for the introduction, and obviously we're following on from what Katie and Dan said, yeah. So I'm Suzan Potts, clinical nurse specialist for HIV in Blackpool, and
I'm Chris Hodgson, like I said. So I currently work in a city of Preston, which is just down the road, about 2-3 miles. That's not a bit more than that, isn't it? Down the road from Blackpool.
15.
But I'm born and bred live in Blackpool, and I've had. When we first started the implementation of this programme, I did move to Preston, but I was like, I'm not letting go of this. Because unfortunately, at the minute, Preston isn't in that, in the high prevalence for the opt-out screening. So I've put a lot of work into this with yourself and I see. So, yeah, so I've not let go of it just yet.
No, we don't want to let go of it. So, for me, HIV testing has been part of nearly all my working life. I'm old enough to remember when it came into place for maternity in 2000 and was involved in that, and all the fears and concerns that went ahead for the midwives at that time. And then we had quite an innovative doctor in Blackpool in about 2013, and we started doing routine testing in AMU. And again, I tried to lead on that. It was very, very difficult, very hard, but obviously we had no idea that this sort of programme was going to be coming into the forefront, 10 years later. So that sort of set me up for that, and then everything went on the back burner. And because a colleague left and there was just nobody interested in doing it. Nobody wanted to take charge of this, and there were so many moans and complaints. And a colleague wanted to do it for his dissertation in ED. So we actually did that, but about that time COVID hit, and that was all the issues with that. So we started it and we stopped it, and that was when we all got into Zoom meetings and MST meetings. And Chris and I did a presentation for THT for HIV Testing Week, and we were quite good on that. We said what Blackpool was like, you know, and what we're doing, and, you know, outside of London, that we're actually doing something up north. You know, we're not just all about donkeys and kiss me quick hats at Blackpool. We caught somebody's eye for whatever reason. When the ED testing, people were looking at who was going to go into that cohort, they realised that outside of London and the 17 sites that were being chosen, Blackpool was also the second highest after Manchester in the northwest. So we were kindly invited to go along and given some funding.
Yeah, so as we said, like we talked about the 20 million before, so part of that, the trial that our colleagues in ED started, so it was anyone that attends for a blood test, so normalising that testing as part of the attendance, obviously when the blood is drawn, and which will help reduce HIV stigma. And obviously we wanted to reach communities which were underserved by testing opportunities and reduce the number of people presenting with late diagnosis. And from obviously the evidence that is out there, because of the 2 years that are there, obviously it's highly cost effective as well. So just go on to the next one. So what did we do? So as you can see there, we've got our poster that we created. That is based on the national programme, and also the information leaflet that we have around the ED department. So, like we said, if whoever comes in for any blood that have blood tests, they would have initially the HIV test would be taken, and then we also implemented Hep B and Hep C testing as well further on.
So, because obviously we're healthcare professionals, there's all sorts of hoops to jump through before we can actually get some sort of movement and ongoing action within.
Hello. Sorry.
Right, we'll move
because
over.
you're not here.
So, obviously we got all sorts of hoops and everything to go through. There's a policy, took forever to get engaged, and there's always people that want to put a spoke in the works. There's always people not keen on it. But we keep bouncing back at them, and we keep, you know, doing our challenging and saying how good it is, and trying to feed back everything that we actually do, and try and keeping them engaged. We needed to develop our own KPIs, performance indicators for the commissioners, so as they knew what we're actually doing, and obviously so we could also feed back to NHS England as well. So we did develop our own KPIs to keep us on our toes, and we set it at 65%, but when we started out we were failing miserably because people didn't want to know. We were going about 26%, so people were just slipping through the net, and people then were thinking that they were being tested, so it had to go on the trust risk register, because if people think they're being tested and then later find out that they're positive and say, why did I never know, and we don't know that they haven't been tested, we could look back exercise, you know, we're in trouble there, because we're advertising that, hey, we're doing this here. So there's been a lot of challenges, and as I say, a lot of unsettlement from healthcare professionals. And again, it goes back to stigma and equality, you know, and why should we be doing it? You know, why should, you know, we not just target certain people? Now, with the figures that Chris is going to explain that we picked up in the last 2 years since we're doing the programme, there's a chappie on there that I just got last week who's 84. Now, he went in with completely unrelated HIV, anything to do with HIV at all, and that just goes to show that, you know, anybody can get it. And if somebody had just been looking at him, would they have thought they would have tested him? No, 84, you don't have sex, so, you know, you probably wouldn't have been, you know, involved in that programme. They would have just assumed not to. So as I say, there's a lot of barriers, a lot of education that we have to try and do, you know, but we've developed our education programme, haven't we? We do a rolling programme of that. And so far, we've trained over 100 ED nurses. The medics are more difficult to engage, unfortunately, because the lead medic for us in Blackpool has been difficult to engage with. I'm trying to put it diplomatically. We couldn't see the benefit of it. And seeing as Blackpool is one of the most deprived, in the top 10 of deprived areas in the country for suicide, poverty, inequality, you'd think that, you know, somebody would be really keen to actually move with something like this, especially for, you know, NHS England choosing us. Anyway, we keep turning up, don't we, Chris? We're like bad pennies, so as they can't forget us and know that we're still here. So
as you can see there, like Sue said, we developed a training programme to train all the staff, including nurses, HCAs, assistant practitioners, nursing associates, etc. Unfortunately, obviously in ED, because of the pressures, there is a high turnover of staff, so we do this on a rolling basis. It's a 2-monthly basis, and like it is mandatory as part of their training as a new initial. And that talks about obviously the background, why it was implemented in Blackpool, the importance of it. We talk about case studies, missed opportunities. So it is quite an extensive, it's a 2-hour training session, but the feedback we've got from that is we've had very good feedback, and it has, since we started the training session, like Sue was saying, we were hitting around 26-30% of people attending for bloods, having bloods taken. It jumped right up to around 80-85%, just implementing that training and getting the word out there. So it was a really successful training program, and that's where we are trying to get into the medics program, but that, like we said, we are having a couple of issues with that. So you can see there, I don't know why, but obviously Blackpool, it's a transient population, and it seems when anyone wants to come to the seaside, they visit A&E as well. So you can see we have high numbers of people attending for the screening. So since we've started, we have had 15 new. So from there, it does say April 2022, because we did the pilot scheme ourselves. So we've had 15 new diagnoses, plus 2 partner notifications. So obviously, when we found someone in A&E, we obviously complete partner notification, and we've had positive results from that. So obviously, it stops onward transmission as well. 5 were known positive, but we re-engaged within services. So again, it helps because, again, like I said, people come on holiday to Blackpool. They might not be in the service in a local area, in their own area. So they've disengaged, they've come out of service. So we're able to, if we got a positive result and they're not known to us in the area, we contact them, find out where they're living. If they're new and they're moving to it, we'll take them obviously under our care. If not, we'll refer them back into their service, check that they are under care. So you can see also there we work very closely with our liver team as well. We've had 18 new hepatitis B, 35 new hep C, and like Katie was saying before, the work that we do now with the liver service, they provide the training session with us as well, and we've got a great working relationship. And then you can see remaining 129 positive screens. They were obviously positives that were known to our services, and like I said before, other services. Thank you. So the only issue that we are still working on, well, a couple of issues is we do get rejected screens, approximately about 50 a month, and it always stays around that figure. And it tends to be, we take an extra blood bottle. Sometimes it goes in the wrong blood bottle, they don't get labelled, etc., etc. So it's more the education and the training. We're hoping that will reduce. One of the big things that we found from the feedback, I provide a monthly dashboard each month, which goes to all the nurses on their sort of staff notice board, etc., about the number of screens done, if we've had any new positives. And like I said before, we do feedback the new diagnoses to show, obviously, the impact is just having that opt-out screen has had on them, and obviously if a lot are late diagnosis.
Yeah, so out of those 15 new ones that we've had, 9 of them have been late presenters, i.e. with a CD4 count of less than 350, which obviously, you know, morbidity and mortality comes into play there. 8 of those 15 have been missed by the GPs in the community setting, and 2 of the GPs had referred them on to the hospital, and they'd been further missed by the services within the hospital and the speciality that they'd been referred to. And whilst we try and educate, it's very, very difficult. And this is where, you know, people just don't want to know, healthcare professionals, 7 had no symptoms whatsoever, which was great. We've caught them early enough to, you know, keep them well and help them with their life. And the partner notification, the 2 patients that were picked up from the fact that their partners were positive, neither of those had symptoms either. We do share with them the success stories of people that we picked up, but equally we share with them the sadness of people that they've missed. And one man in particular plays on our minds, a 40-year-old gentleman that sadly passed away because 3 times he went into ED and 3 times he wasn't tested. Whether the outcome would have been different, I don't know. But his partner, instead of they were planning the wedding, he ended up cancelling it and obviously planning the funeral. And it is very emotive, that, and I think when people hear that sort of thing, and it's not to point fingers of blame, it's just to say what can happen, because you can't judge a book by its cover. None of us in here know what each other does sexually. It's none of our business, is it? So therefore, we cannot judge patients by that. So the challenges that we have, next slide, Chris, because I'm sure we must be running out of time. Challenges are numerous. COVID obviously was the first one. However, you know, it ended up being 2 minutes, thanks. Oh, like that. It ended up helping us because obviously that was where people were engaged on Teams and everything, and it was we would never have showcased what we were doing in Blackpool at that time if it hadn't been for COVID, and we got our message out there.
So again, initially it was the staff engagement and buy-in. There are still obviously issues with that, but like I said before, just reiterating with the training programme, the dashboard, and we do take, we survey obviously the training sessions. Is there something we need to, you know, bring in, discuss, etc. Biggest one for us, which is still ongoing after all this time, is automation. It is very, very close, but for some reason Blackpool is the only hospital that uses a certain specific system within their department, and to get automation into that computer system, so to get it into an A&E profile, so it's you know, the blood, they don't need to think about it. It's very challenging. I'm sure the new sites that are coming on board, that's probably one of the first things I would advise start off with if you can, because obviously as soon as you get automation, it helps massively. So, and then obviously we've got the leaflets that we are working with to get them in different languages, and obviously because currently it's a QR code, and we have banners and the posters all around the ED department and the leaflets as well.
Providing somebody doesn't take them down if the trust is being decorated.
When they're decorating.
And then, you know, and we have to go back and say, look, it's our informed consent up here, so please don't take them down. But you know, for us, the challenge is we don't give up. We don't give up. We just keep going back time and time again. And with the support from our colleagues at NHSE, you know, we believe that we do make a difference. In the conclusion, you know, our screening programme has gone from strength to strength. We're not automated, so to achieve 85% without automation of bloods is absolutely amazing and a credit to the staff that take those bloods. You know, and that's not us. We don't do that. We just pick up the pieces afterwards. But we're lucky in Blackpool, we have one lab, and they phone us to let us know they've got a positive result before it is released, and we can look at that and work that out and try and manage that, and that takes away the fear from the staff in ED who think that they might be tasked with dealing with this and perhaps not enough knowledge. So we know that obviously the theme is prioritising equality and impact. What, am I shutting up?
Yeah.
Have I run out of time? Okay, so we're doing great. Thank you.
Thank you.
Passion really came through there. Fantastic, thank you. Okay, so next up is a project I know because I'm working on it. So I'm co-leading the national evaluation of ED testing, and with me are colleagues is Tom, who's leading the qualitative evaluation of ED testing, and Tom's a research fellow at the University of Bristol. And with him is Siobhan, and Siobhan's a senior research associate in research at the University of Bristol, and Siobhan's leading the qualitative data collection, and they're going to speak to you about what we found.
Thanks, Jeremy. Hi, everyone. As Jeremy mentioned, we're going to be speaking about our qualitative work around the implementation of opt-out testing. So this was a qualitative study looking at, as Susan and Chris mentioned, around sort of challenges and solutions that sites face when implementing opt-out testing. So hopefully it should follow on quite nicely from what you guys spoke about. Apologies, this is probably quite similar ground to what we all know already, so I'll skim through it quite quickly. But as we know, in 2022, NHS England launched opt-out testing in 37 EDs in areas with very high HIV prevalence in London, Manchester, Blackpool and Brighton. And through a partnership with the Hep C Elimination Fund, Hep B and Hep C were later added to form a kind of combined approach to opt-out testing. The aims or the goals of the programme really are, as we already know, to meet viral elimination goals. So that's a 2030 goal of reaching zero HIV transmission, and also eliminating Hep B as a public health risk and Hep C transmission. To do this, we need to increase access to testing, so we need to scale this up to reach people that have undiagnosed infection. Obviously, EDs offer a point of care which is accessible to all, so it's able to reach those people that maybe don't perceive themselves as being at risk or face barriers to existing other forms of testing. And finally, by presenting testing as routine care, opt-out testing can also help to normalise testing and reduce HIV stigma. And as the co-presenters have mentioned already, this year we're also seeing a recent expansion of opt-out testing into 47 high prevalence HIV areas. So the pathway that opt-out testing takes, so anyone aged 16 years or over who is attending ED and having a blood test is automatically tested for HIV, Hep B or Hep C unless they explicitly opt out. Patients are informed by posters and banners that are placed in EDs, which also provides information around how they can opt out of testing should they wish to. Patients are contacted by relevant or specialist teams if they have a reactive result, and they're then supported to engage or re-engage with care through those services. So it adopts a no news is good news approach to results management. So in terms of the work that we've been doing at the University of Bristol, in collaboration with UKHSA, we've been evaluating the first rollout of opt-out testing that started in 2022. And there's three work streams to this work. So there's a public health evaluation that's been led by UKHSA, a cost effectiveness analysis that's also being conducted by the University of Bristol, and a qualitative study looking at the implementation of the programme, which myself, Jeremy and Siobhan are working on. In terms of the aims of this work, we were looking to optimise the delivery of opt-out testing in very high HIV prevalence areas to increase test coverage and uptake. So looking at what was going on within those sites, looking at any issues, and then feeding that back rapidly to inform implementation. There were two stages to the work. So the first stage was to describe the different strategies of EDs to implementing opt-out testing. So last year we published that where we obtained SOPs from all of the 37 sites and looked at any variation or consistency across sites and how they implemented it. The phase two, which is what we're talking about today, is again looking at those issues and barriers to opt-out testing. So that was through qualitative research with both patients and staff within EDs. And as I've already mentioned, this was looking to develop recommendations to optimise future implementation. So using that feedback to help shape both implementation within very high prevalence areas, but also for the new rollout as well. So in terms of our methods then, we selected 5 ED sites involved in the first rollout, and we conducted interviews with 21 staff involved in the delivery of testing. All interviews were conducted remotely via Teams or telephone by Siobhan and myself, and they were all conducted between April and August of this year. And yeah, as I said, yeah, findings identified any challenges and solutions to implementation. And in terms of who we spoke to, we've got a mixture of people. The majority of the people were from ED, so healthcare assistants, ED doctors, nurses, but we also spoke to people within labs as well, and also a HIV nurse and coordinator, and a hepatologist as well. In terms of the challenges and solutions, I'm going to pass you on to Siobhan, who's going to talk you through those.
Thank you. Might be a bit smaller. So I'm going to talk to you about the findings that we found, and just to kind of highlight Chris and Sue's work, because one thing that we've seen across all sites is there is people there tirelessly looking at all the challenges and looking at all the solutions. So we were actually really fortunate that a lot of our solutions came from the sites that we were working with. So they were kind of what one site was doing, and so we have kind of said that actually that has worked, and so we wanted to kind of see where those were coming from. So it really is people like Sue and Chris batting down the door, kind of going, let's do this, and Blackpool are one of our sites as well. So you may see some similarities in what we're talking about today. So the kind of one of the biggest challenges and one of the biggest things that was coming across was staff knowledge and understanding. We know from talks this morning, you know, knowledge and stigma still is in healthcare. And so the inconsistencies that we saw across sites were some sites had really good training, and some sites had nothing. And also it was some sites, doctors were getting training, but not the healthcare assistants. So it was about, looking at those inconsistencies and what happened when there was no training. So the people that we interviewed were really positive about the opt-out testing. However, they still had low levels of knowledge or understanding, and they couldn't talk to patients about it. So there was times where they would just say, I would just say, talk to your doctor, because I don't know. So it was about them kind of agreeing with the initiative but not having the knowledge. And also there was examples of outdated views and stigma. And moving on. So one of the solutions is to have really good training, but we also are aware that we have very busy EDs, so we need to make sure that this training is accessible and concise, and covering some key topics. So we looked at some key topics, so information around blood-borne viruses, the purposes of testing and the elimination goals, information about follow-up care, so people could actually kind of one, know that they didn't have to do it, because that's a really important thing for staff, but also that they could tell patients that, you are going to be seen by specialist services if you come back as reactive. And the community support organisations, and that staff know about those community support organisations and the peer support. And one of the big things that came out, and I've just been to a talk that highlighted this as well, was where staff had somebody who was living with a blood-borne virus as part of their training, the impact of that was massive. And they said that was why they understood that this testing initiative was good, and that's why they were continuing to include the test, because they had somebody living with the virus, and they could see even better if that person had been diagnosed through ED, but obviously we're at the beginning of it, but it was really, really impactful, and we can see here from the quotes that was highlighted. So the next one is around how do you embed routine testing? How do you make it going from exceptional tests to actually this is just something that we do? Chris obviously already highlighted the automation. So for people who don't know, some sites have it that when you do a blood set, when you order your bloods in ED, you're automatically the blood-borne virus test is automatically added. So it's kind of little thinking for staff. But not a lot, but some of the sites have funny IT systems that don't allow them to do it, and you're not the only ones, can I say. There is lots of sites that their systems don't allow them to automate. And some sites just can't financially, or for whatever reasons, this isn't going to be a thing. So we had to kind of think about things for those sites that couldn't automate it. How could they be helped? And the other challenge was around the extra vials. So a lot of the times blood-borne viruses are taken in a yellow top, which is the same as the use and ease, and kind of staff would be routinely just doing one yellow top. And so they were even if they had it kind of collected, they would just, oh no, I don't need that. Why do I have a second one of those? So it's kind of like, oh no, I don't need to kind of include this. So some of the solutions that we talked about, so in sites that without automation, they talked about having posters up in the staff areas, post-its on the computer sometimes, just like little reminders around blood-borne viruses, and also verbal reminders by the leads at daily huddles and handovers. But these all need people like Sue and Chris who are going to, you know, talk about it, but also people in ED, and the buy-in from ED is really important. And then the other thing that some sites were doing was using a different colour vial. So they were using red tops instead of yellow tops, and that just gave that staff the visual, oh, this is a different test, I need to remember to do it. And actually, it was in one of the sites, there was a healthcare assistant who thought about this and introduced it within their site. And then one site also has a different size. So just little changes that actually meant that staff were remembering to include it. And allowing time, like change, embedding normal testing doesn't happen overnight. And I think if we expect it to happen overnight, it's not going to happen. So allowing that time, providing staff support and effective ways to feedback. So if they see, look, these bottles aren't working, and making sure those communication lines are open. And again, we see from Sue and Chris, like their numbers went up once they started to implement some things. So I think it's really about embedding it within EDs and giving people that time to do that. So, patient knowledge of opt-out testing. So staff were really positive about the testing initiative and about the fact that it was opt-out. But one thing that they were unsure about, and actually probably for some of them felt uncomfortable about, was whether or not people actually knew about the test. And this wasn't about them getting consent, it was more just about whether, you know, the patient knowledge. Whether or not they're being tested, and also, was this a missed opportunity for some health promotion, health education around blood-borne viruses? What could they do? But on the flip side, we're very aware that they're very busy EDs, and it's not always that easy to do health education. So one of the kind of solutions to this was around having standardized scripts so that people could kind of, if they felt that the person in front of them wasn't informed or may not have known, they could easily say, we're doing routine testing for blood-borne viruses, as part of it. And then also having the knowledge for if that person then asks questions, that they know where to signpost them. They know which website or which, sexual health clinic or where they need to sign them. Okay, I really need to speed up, sorry. So another kind of issue that came up was around workload and competing priorities, and people not seeing this as a priority. This isn't a test, I've got many other things that I need to be doing, and this isn't something. But on the flip side, staff say this takes 30 seconds. It's really quick. It doesn't take over. It doesn't do anything. So actually, it doesn't need to be a competing priority. And I think part of that is about the importance of promoting universal testing and what that does. Sending out emails, this is the amount of people we tested, sending out things to tell them so that you're getting their buy-in, because if they have buy-in, they won't see it as a competing priority. They won't see it as something that adds to their workload, because in reality it doesn't, but it still has that sense of it.
I think I've got about a minute to go through these. So, so we came up, based on our findings, we came up with some kind of recommendations that can be used in additional sites. The first of these was to foster staff buy-in, so similar to what Chris and Suzan mentioned. Honestly, we hadn't seen your slides before, so we didn't copy you or anything. But yeah, making sure that we promote the importance of testing to all staff. And as Siobhan mentioned, as we've heard before in some of the other talks, having people with lived experience to really kind of promote the importance of it and, make training more impactful is really, really important. Providing staff education and training, so ensuring that all people were provided with training, so right through from people that are actually delivering testing to actually overseeing the programme as well. Supporting ED staff in testing all patients, so at sites that are not automated, using things that can help support them, so reminders in consultation rooms and so on. In sites that are automated, just changing maybe like the colour of the vial top. Efficient patient communication processes, so if there are concerns about whether a patient has seen information, just having like a script or something like that that can just not disrupt the workflow or patterns of how people are working. Closely working with specialist HIV and hepatology teams as well, so we found that at sites that were working really closely with both those specialist services and EDs, EDs felt really supported to implement the programme. And we kind of hope that in sites where we're all implementing these procedures and once it was up and running, we found that actually it really helped sort of normalise and embed testing, and we hope going forward that as the rollout is expanded, we hope that more sites can follow these procedures and help to kind of implement testing as part of a normal part of routine care, just like any other standard test. Just some acknowledgements. So we've got we work closely with UCL and also their HPRU there, and also UKHSA and Fast Track Cities Bristol. If you would like any more information about the study, there's a QR code that links to our website as well. Thank you very much.
Okay, can everyone, is this working? Yeah. Can everyone, the speakers come back to the stage? I think we need to bring a couple of chairs. Gonna run out. Okay, so we've got some time for some questions. I'll let you rearrange the furniture first. That's enough.
Are you going to sit down as well?
No, I'll stand up. I'll stand up. Okay, so there are any questions? Yeah.
Hi, we're from Lincolnshire and we're quite a rural area. When would the opt-out be introduced to more rural areas? And also, there's a lot of people who are against, I wouldn't say there are a lot of people against testing, but how would you encourage them to take part? Because there's a lot of people who are not knowledgeable enough to, if you know, I'm mumbling, but obviously educated, and how would you promote the testing as well?
I would say that. There's a microphone on the table.
Is this working?
Yeah.
Yeah, so I think, well, one of the things from our point of view with the expansion has been that we had these really clear recommendations from NICE and from BEVA, that it was initially at least very high prevalence areas that should be doing the testing. We're hoping that you guys in your study will come up with some conclusions about exactly where it makes most sense to sort of draw the line, and we will build on that essentially. So, I mean, obviously it would be a dream to be able to do it everywhere. We've got to make sure that we continue with the funding first, and we'll be using the evidence from the new programme, definitely in policy and advocacy spaces, to think about what the next case is. There's obviously nothing to stop individual hospitals from getting on with it if they want to in the meantime. Is that a fair assessment?
Yeah, I was going to just add. Yeah. I was just going to add to that, you know, if you as a hospital feel that this is something that you should implement, it's about making a business, you know, at the moment it is just this, but it's about, you know, I used to be a HIV specialist nurse and we did it in Reading 10 years ago, and it's kind of about finding those things, but it's also about, not just about universal testing, but actually educating your staff so they're even just testing people who may have HIV indicator illnesses kind of coming up. So even if you're not testing, the education side that Sue and Chris are doing is really important, and actually that can start now, and increasing education across the hospital is really, really important.
Yeah, just to kind of add quickly, I guess, and just reflecting on what Kevin said this morning in terms of where we are in the epidemic and what we need to do moving forward, which is, you know, kind of, it would be brilliant to have, as Katie said, you know, this everywhere, across the country and universal. If that is not possible, we need the right system in the right places to be able to get to 2030 and reach the people we're not reaching now and who haven't been reached through the process that we've got at the moment. So that will mean looking at different areas, looking at different populations and looking at that strategically in terms of have we got the right testing system in the broader kind of scope to meet the needs of where we are now in the goal to 2030 and ending transmission. So I think it's that strategic oversight needs to drive where the interventions and programmes are prioritised for the next round of funding if we aren't able to get to the perfect, which is all testing everywhere.
So Chris and I do this role on top of our own clinical work with our patient cohort. You know, so that can be quite difficult, but it's about finding the right people who want to be engaged with it, you know, and identifying those people. We have found one nurse in ED who's really, really sort of buys into it, and as I say, she makes sure everybody is given time on the off duty to attend, and if they don't attend, she wants to know why, because it's part of their, you know, rota for that week. And we've also made sure that we're visible on World AIDS Day, and we've done Hepatitis Day this year, where we actually go to the hospital in the mezzanine area, and we just have put boards up. We did a quiz, didn't we? We got 600 forms, and we're going to redo it this year, and it was scary to think just how many people didn't know the basics even of HIVs. But education is key, and certainly in your other areas like for HIV indicator illnesses, they're missed time and time again. I've just put in an untoward for a chap that was missed 7 times in specialities, you know, and it's trying to raise that awareness somehow.
Yeah, so that's exactly what I was going to highlight, is the fact that it's about education, because obviously people don't know what they don't know. So if, for instance, we'd like to saying on World AIDS Day, we do have a big presence in the hospital, and we were quite shocked because we did a stigma awareness survey just about how come into contact with HIV. Are you aware of even the testing happening in ED? And we actually thought the footfall that we thought we'd get would be the general public, but actually it wasn't. It was nursing, obviously healthcare assistants, and it was surprising. The knowledge wasn't there. There was a massive gap around HIV testing, even PrEP, the U equals U message, all that information they didn't know the information. So a part of that training isn't just about the ED projects, it's about the messages that we need to get across, how to access PrEP. And we do it, as much as it is an extensive 2-hour session, it's got a lot of information in that, but then we always try and have that presence at World AIDS Day, and now we've linked in with the hepatitis, the liver service. We do have that. We are there to promote the messaging. Like Sue said, we are trying to because of the training we've put in place now, we are trying to obviously reassess that and see if there has been a change in the information, people's knowledge about testing and HIV. Yeah.
Bribery works very well for healthcare professionals. We like a pen. We're very easily pleased, and we were pleased with the bag this morning as well. That was extra bonus. But we always bribe with pens and key rings and trolley tokens, and you'll get a lot of people at your stall.
One site bribes their ED with cake.
Just to follow on from what everyone else has said, obviously I think education is the main thing, but it's also about making that education accessible as well. So EDs are obviously really, really busy places. You know, taking time out for staff to go and train can be quite tricky as well. So you know, finding ways to make it accessible and you know, not saying to cut corners, but you know, in formats that make it you know, where you don't have to essentially take half a day off work to go and do that as well. So I think that's something that we've been quite keen to kind of explore going forward, just that, you know, how can we make training accessible and easy for people to digest going forward.
And part of sort of the wider rollout, I think that's why our national evaluation is really important, because the government's going to see they've invested this money, what they're getting for it. So part of us finding out, you know, how successful it is and actually how cost effective it is really important for the next steps. So, okay, thanks. Another question?
Hi, I'm from Hampshire Sexual Health, and we cover the whole of Hampshire and the Isle of Wight. We've got 3 EDs rolling out testing very soon, hopefully, and we very much support that. I've not seen much research into the impact on sexual health services who are doing the follow-up testing for HIV and the increase in the caseload of HIV positive patients that will result from this. I know it's very early days, so there's probably not much data there, but we'd really like to see some research into that to help us with costings and predicting the future caseload.
Yeah, so our first evaluation was more based on the implementation, but we're now evaluating the next rollout, which we are going to be looking at that follow-up stage a lot more. Some of the things that came out of the public health evaluation was that the people who were engaged in care was lower than people who were tested through sexual health clinics. So I think that's something we really need to explore in more detail. Why is it? And it probably has a lot to do with, you know, being in an ED, but then what extra supports do then we need to put in place. I know this is about HIV prevention, but one of the big things that came out of the first rollout was that Hep B cases were a lot higher than people expected, and so that has been an area that needs a lot more funding and a lot more put into it. So I think as it rolls on, this is something that we will evaluate further, and probably Sue can give you on the ground experience.
So for ourselves, we do test slightly different than everywhere else. We do our test from a separate tube, and it goes directly to virology to do the testing, rather than on the same sample as U&Es, simply because it gives a lot less false positive results. So we do get like an influx of false positives, and that is managed by the HIV team, simply because we are the area, so they don't go anywhere else. We get a handful of those, or a run of those, so it doesn't impact. But again, it's something that I have to pick up separately, other people that I work with, because Chris is based in Preston, so he doesn't actually get involved with the results in that respect, do you? So the positives, the ones that we do pick up in ED, obviously we just bring in straight away, as you would with any new positive. So you just make... I'm sorry, say that again. Yeah, well, so is ours. We've had an increase of over 40% and not of HIV positive patients attending our sites, and no increase in staff whatsoever. You know, it is appalling, because obviously it's not been reviewed for the last 20 years, and we are getting that increase. But at the end of the day, we just keep rolling with it. Hepatitis B, like we said, it's a national picture where they're picking up loads, and there's no clinics in place. And there's a doctor called Stuart Flanagan in there, who is looking at how we're going to set up clinics for that. But we're also trying to do that in Blackpool, aren't we? We're working closely with the liver service to try and set up a clinic. And also for the indeterminate or false positive results, we want to employ somebody to deal with those, because while it does take time, but that'll come out of the funding monies, so and may not attract somebody because it's not a long-term post, you know.
One of our issues is because we've got these 3 separate trusts providing the emergency department services, and we're one trust providing the HIV specialist service. We've got to negotiate with each of those trusts for a slice of that funding, and that's proving challenging as well. So,
well, we didn't even get our funding. It went to Manchester, to the Integrated Care Board, and they hung on to it. Didn't even notice that they got it. We've had to beg it back, haven't we? You know, but yeah, it's... Every little bit helps, and I mean standardising. We work with a good pathology team, because again we just have we don't have a joint path lab thing, do we? Did you want to speak, Chris?
I was just going to say the funding is, because obviously we went from 26% of the total people who are attending A&E to 80%. So then the majority of the funding just becomes testing. So when you start to try and look at roles, like I know Manchester have like a tracker, results tracker, someone who will then chase the false positive, etc., which is an invaluable role. But unfortunately, we just in Blackpool don't have that funding because obviously the more testing you're going to do, yeah. But I'm sure that will come in the reviews.
Okay, is there another question?
Did you get any funding towards peer support at all?
In what respect?
So have you got peer support? Did you get any funding to increase that?
No.
The new
Yeah.
rollout, the 10% is going to community. I still think funding is very, very tight, but the new rollout has got 10% going to community organisations. So funding is still extremely tight and only covers testing, but there is some funding.
Chris and I,
Yeah.
we're backfilled about half a day each to provide this, and it takes us far more time.
Yes. And so, you know, one site, their Hep C nurse goes down every morning to get...
That's awesome.
Oh, is it you?
It's awesome.
To me? Oh, well, then another site as well, though, does. They go down...
They're out every morning to check what's going on and see if the posters are up.
Yeah, and...
Been ripped down overnight.
And also just to pick up the bloods from one pathology and to walk them to another lab because they were getting lots of inconsistencies in that. So there's a lot of little things that has to happen. And Hep B in some sites have 9-month waiting lists. So I think it's really important and the funding is so vital and it's really great, but we just have to make sure that we show that there is
a need.
Yeah.
Any other questions?
Hi, my name's Leon. I'm from Trade in Leicester. It's sort of a two-part question. What training, obviously when someone gets a reactive result, language can be really important in delivering them that. What training is given to any staff delivering that language, delivering that news outside of HIV services? And perfect timing, I think we're hoping for a slice of that 10%. To provide some peer-led support for people with new HIV diagnoses. So if there was one thing that you guys think would be useful for someone newly diagnosed with HIV, either through in-person experience or through this project in any way, what would that be?
To answer your first question, I can only speak for Blackpool, really. It's only the HIV team that manage those positive or reactive and false positive results. So the staff that work with me already have that knowledge base on how to give that information, because obviously it's a bit like cold calling. We've never met them, we're phoning them up, we're asking them to come in. And as for support and everything, we do the support, but we work very closely with Horizon, who have a counselling service and buddying service and everything else, that's singing and dancing, and going to be Revolution as well. So, you know, we work very closely with that, but that's just us. We're just lucky in Blackpool in that respect. Do you want? So, does that answer your first question, bit of it? Sorry, what was the second bit again? The slice. Oh, gosh. I don't know, Chris. Get your thinking cap on.
Well, I think one of the, and I think it's come in other talks with regards to having peer support in actual a clinical setting. We have our third sector, obviously, which is Renaissance Healthy Living. This is in the Preston site currently, but obviously having them actually inside, they have a clinic that is run by the support workers there, which is invaluable to us when, obviously, if I do get a new diagnosis within the clinic, I can literally refer them into the next room because they, you know, they're actually on site and there's no waiting, there's no. But also, if someone's in crisis as well, it's again there's that support there. You know, so that I think that's invaluable going forward in the future.
I would agree. And I want that at Blackpool, but we've not got the room as yet.
Yeah, just on the answer the second question, if that's all right. I think one thing would be that's really kind of, I'd be hoping that we can kind of roll out and make a positive kind of change with is at the end of this year, the HIV confident charter mark is going to kind of go beyond its pilot phase and into kind of a wider rollout. And I think every hospital where it's got an opt-out programme in place and in a high or very high prevalence area becomes HIV confident, because all of that stuff you were talking about, Siobhan, around the kind of the training, the people side, just that kind of awareness and knowledge, you know, it's great where hospitals are able to do that with ED stuff, but actually if the whole organisation, if that whole hospital, the trust, is able to kind of show that they are HIV confident and that people have got awareness, that we're challenging stigma, preconceptions, all of those things. So I think if we can align that kind of wider goal around awareness, knowledge, challenging stigma, and looking at, you know, the charter mark is not the only way we can do that, but it might be one way, to then go alongside the actual kind of mechanics of the opt-out testing, I think would be really impactful in terms of then making sure that the people are getting that right experience and the right support at the end of it.
Anyone, anything to add?
Okay. One very last quick question. Anyone's got one? I was going to ask about the training you do. So it's a 2-hour training. So what's the uptake like of that?
They have to go, they don't have a choice.
It's mandatory.
Because they're actually, sorry, they have to go, the nursing staff. They don't have a choice, they're rostered onto it and it's part of the weekly roster. So they cover the, you know, so that's great for us and it works. Because some people, you know, just used to take a sly day off and just think, oh, I don't need to go to that.
Yeah.
But they have to actually sign in and prove that they've been. So that's good. And we're hoping to get in with the medics this autumn. But it's good, we get good feedback, we do evaluation, we try and change. But there hasn't been any sort of negative feedback on that. So we seem to have got it reasonably okay, but it's a lot to cover in a short space of time, and trying to make it impactful and meaningful to the staff and make it sort of alive for them as to see why it's so important, this project. So sometimes we sing and dance, Chris and I, don't we? You know, just try and make it fun.
Exactly, if it makes an impression. So, we can see from from
yeah, he
Siobhan's,
wears a wig like mine just to confuse people.
we can see how important that training is, though. So if people...
assistants as well?
Yeah.
Yeah, so they do with the nurses and the health assistants.
Okay, I think it's time for lunch. So thanks, everyone. Fantastic session.